We are live, please.
So, good evening, postgraduates, and my regards to all the mentors. Today is the 150th episode of our All India Online PG Teaching Program, which is an initiative of ARC AIOS. Well, it was in our last 10 year when we initiated this program, as AIOS per se did not have any particular program for postgraduates dedicated to them. And it makes me really very happy, rather the whole team, for getting us over here. And we have been doing this since last 3 years uninterrupted, except for some national public holidays. So let me congratulate my team members who are there, Dr. Chaitra and Rajesh, and the whole team for this particular effort which you have been putting. And it's only effort of my whole team that it is possible for us to continue uninterrupted and have new set of speakers and a galaxy of speakers who are so well versed and very well known in their respective fields. So my sincere most thanks to Chaitra and Rajesh for pulling out such a big galaxy of speakers for today's episode for our postgraduates. So without much ado, can I request today's moderator, Dr. Chaitra and Rajesh, to carry forward? Just to make a frank admission, today's whole program, rather nowadays whole PG teaching program is designed by the moderators. They are responsible for curating the program as well as inviting and getting the best of the speakers for this particular show. So without much ado, Chaitra, over to you.
Thank you, Dr. Prashant, and the trust you've placed in all of us in your team. So proud to be part of your team and to work with you. So this is in continuation to the ARC PG training program that we've been having. This is an initiative taken along with AIOS, and the beautiful part of this particular initiative is that it covers all the different aspects that's required for postgraduates, especially when they appear for exams. So since it's online, it's accessible and recorded as well, so they all can watch it anytime. Last week, this entire month, the theme is retina. So last week we did some of the short cases, and the discussion was fantastic. All the PGs did great. This week we're going to the OSCEs, and we have the experts themselves who are going to tell us more about kind of spotters that you could get during your examination and during your clinical examination, and what potential questions could be asked. So those of you who logged in from other modes of the telecast, you can send in your questions if you have anything in particular for the mentors here. Besides that, we'll also have panelists, throwing in their expert advice as to what can be potential questions, because they're all examiners in their own right. It's a pleasure to introduce our panelists for the day. Uh, First, we have, I don't know if you can see my slides. Just give me a second.
Yeah, we can see. You can have it full blown. You can have it as a full. Yeah.
Okay, so first up, a very good friend, Ashray. He's from my own city, so gives me more pleasure to introduce Ashray Naik. He's a senior consultant, vitreoretinal at Eye Foundation, Coimbatore. He's also a medical legal consultant and is a clinician scientist. He's completed his training at BMC and MAMC and a long-term retinal fellowship from LV Prasad. PGDMLE and from the institute NLU itself. A lot of innovation and ventures. He has patents pending. He's a co-founder of several initiatives. He's also received several grants, and he's won 4 best papers, TNOA state conferences, first place at the Otley OS 4 retinal surgery session, and he's presented at the JM Pava session as well. Next, we have again a dear friend, Dr. Divya. She's a vitreoretinal surgeon at Little Flower Hospital and Research Center, Angamali. She's completed her DNB from Little Flower itself and her FNB in retina from the LV Prasad Eye Institute. She's been a former faculty at LVP and at Giridhar Eye Institute, and she's published in leading national and international journals and presented extensively at major conferences. Her video on pearls and pediatric retinal surgeries was selected as the top videos in ARC 2023. Next, we have Dr. Pradeep Sagar. He's a consultant VR at Shankara Eye Hospital, Shimoga. He's an advisory board member for the Springer Nature Ophthalmology and Therapy. He's also served as the deputy editor of the VRSI newsletter between 22 and 25. over 70 publications and 15 textbook chapters. He's a recipient of several national and international awards, including the International Ophthalmic Heroes, the PN Nagpal Hack the Tech Award, the IGO Gold, the IGO Honor, and the AS Guru Prasad Award for the Best Medical Retina Paper, and also the Best Mentor at COSCON 2023. Without much ado, let me hand over to my co-moderator, Dr. Rajesh, to take the proceedings forward.
Good evening, everyone. Thank you, Dr. Chaitra. It's great pleasure to introduce my friend Dr. Anand Vinekar, who has done MBBS from St. John's Medical College, Bangalore, and MS and senior residency from PGIMR, Chandigarh. During his MBBS days, he got 17 gold medals, and during his residency, he got Kataria gold medal from Prime Minister of India. He did his fellowship from Michigan, USA on pediatric retina. He has also done PhD in ROP from Netherlands. He has over 125 publications with H index of 37. He has to his credit 24 chapters and 1 textbooks as well. He has got numerous awards. Prominent amongst them are Colonel Rangachari Award, AIS, E.T. Shelvam Award, P. Seva Reddy Award, and many more. With no conference on ROP goes without his presence. Presently, he is heading the Department of Pediatric Retina at Narayan Nethralaya, Bengaluru. He is a founder program director of KID ROP, founder secretary of Indian ROP Society. With this, I present to you Dr. Anand Vinekar. He will be talking on pediatric retinal imaging.
Thank you, Rajesh. Thank you, Chaitra. Thank you, ARCIOS, Dr. Prashant, and the entire team. It's an honor and a privilege to present here, particularly to the residents who should be getting well versed with these topics, because some of these topics are not normally covered even in normal postgraduate training. So I'm very happy to and friends of mine who are presenting here. So we've kept this talk very practical based. I'm just looking at the time, so I don't want to exceed. And it's all going to be based on your questions. So these are getting you ready for possible spotters. Yeah. Okay, so now imaging a baby is not the same. Baby is not basically a small adult. So you can't suddenly take adult cameras and start imaging the baby's retina. And for some of these reasons, which are listed here, but the most important one from a logistic purpose is the fact that the baby has to almost always be supine. Whereas an adult, unless very uncooperative, is usually sitting up. So therefore, tabletop cameras are very useful for adults, but in a baby, you can't do that. So that's one. The second one is, of course, the cooperation, especially if you're referring to an infant who's not even been able to fixate. So that's one. So this basically means that if you have to take pictures of a baby's retina, the entire camera system has to be handheld. So that's the important word here, an handheld camera. And well, the other the differences are obvious. So the challenge is not only what to image. Okay, yeah, we want to image the retina, maybe the anterior segment, but how to image it, that's become a problem. Now, what are our available imaging tools? Now, technically, the most common way of looking at a baby infant's eye is the indirect ophthalmoscopy. And unless you have a video indirect ophthalmoscopy, you're not being able to take images. So this is a great clinical examination tool, but not an imaging tool. Since today we're talking about imaging, let's go with the rest. So these are the most commonly occurring ones, and depending on where your exam is, you might actually encounter one of these cameras. So what we've done in this talk is to keep it to the more common ones, which you might be asked what it is, and then you might be asked questions on it. So this talk is going to prepare you for that. So the more common ones is the RedCam, which is an American system, and Trinetra Neo, or popularly called the Neo, which is Indian. The others you have is the handheld OCT. So we'll talk a little bit about this. Again, important word, handheld, because OCT, anyway, Dr. Shailaja is going to talk to you about, is otherwise a tabletop. And then angiography, again, it's not the Heidelberg or the Topcon systems that you're used to seeing for adults, but again, a handheld device. So it's one of these pediatric cameras has to be able to do that. And the OCTA, currently we do not have a handheld OCTA. So the only one is, you saw the picture of the baby here, what's called the flying baby position. So this is an important term that was coined by C.K. Patel many years ago from Britain. And that's how you have to hold a baby, sometimes even more slanted if you have to use an adult device. So the question, can you use use an adult device to take pediatric cases? Yes, you can, but then these are the logistic issues. So today's talk is going to mainly focus on the two retinal cameras, and then we're going to quickly, briefly go through the rest. So in the spectrum of wide field, why is wide field important? Because the pediatric retina, a lot of the disease and the most common most common use of the camera would be ROP screening, retinopathy of prematurity screening. I'm not going to get into the details of that, but that since the disease is happening in the corner, in the periphery of the retina, wide field is important. Now, the standard adult cameras are not wide field, they're more narrow field. So they go from 45, but of course they go all the way up to 200 degrees, which is the ultra wide field. So somewhere in between 110 and 130 is the wide field nature of pediatric retinal camera. So that's again a number you might want to remember, 110 to 130. Now, these are two cameras that you might see depending on which center you go for your exam. The one on your leftmost is the big RetCam, which is called a RetCam 3. It's different because, and how do you identify this? It has a desktop in the sense that there's no laptop here. The screen of the computer is fixed directly. It's only movable in one axis. It's not a laptop that you can remove. What does this mean? It is not portable. So the second photograph on your right is the portable version, and that's called a shuttle. So how do you identify this image? It's the RetCam, and that's the trade name. So is this contact or non-contact? Now, this is an important term in pediatric retinal imaging. Contact means being placed on the cornea. So of course, before directly putting it there, you're using topical anesthesia, using a coupling agent, which is usually a gel. But yes, it is kind of touching the cornea. So it is contact. Non-contact is from far away. You saw that flying baby position, that would be non-contact. Even the OCT is non-contact, but we'll come to that. What is the field of view? As I told you, it's between 110 and 130 degrees. Where is it commonly used? In retinopathy of prematurity screening. And what disease are you most likely to image it in? Yes, ROP, but then also retinoblastoma and other conditions. This is the other camera you're more likely to see in an exam because this camera is now more widely used across centers and hospitals. And so what is this? This is the Neo camera. This is the Trinetra Neo or the Neo. This was made in India. This was made in about 2015. It's now 11 years old. Is this also contact? Yes. What's the field of view? It's about 120 degrees. And the RetCam was 130 degrees. What's the main difference? The main difference, if you have to identify, is at the handpiece. So whereas the RetCam is going to be the lens can be dismantled and another lens can be put. The Neo is a unibody. So if you look at the camera, if they give it to you in your hand and you look at it, the black portion is a lens. It cannot be removed. That's how you identify a Neo from a RetCam. So what additional imaging can it do? Well, this can also do an angiography. So we'll come to that. Again, common pediatric retinal conditions are the same. So if you're given a spotter, this is how you should answer. This is a Neo camera or a RetCam camera. It is a contact wide field pediatric retinal imaging device most commonly used for ROP screening. So that's the good answer. This is how it works. Just a quick video. So this is as you can see, it's contact and whatever is getting image here is coming on the laptop there. So there is no fixed version in the Neo. It's portable completely. Whereas in the RetCam, you had a fixed version and a portable version. So here's our comparison of the two. So if you're shown an image, more likely, you're not going to be seeing the camera. So here what you're going to see is if it is a rectangular image. So if you see the orange colored image in front of you, that is the RetCam image. So rectangle, RetCam, you can remember it that way as a mnemonic. And that's because it is a rectangular sensor inside. And that sensor is 1800 into 1600. You don't need to know the number, but it's good to know that they're not equal numbers. Whereas if you see a circular image, it is the Neo. Okay, so again, mnemonic is O for Neo, and that's a circle. Now, advantages, you get an extra arc of the superior and inferior retina. So that's an advantage. Of course, it's lighter, it's much more affordable. The kind of lens is different. This is a little bit theoretical, but if you're shown an image, if it's rectangular, it's RetCam. If it's circular, it's Neo. So now if you are, okay, the examiner goes beyond. Now they say, describe this eye that you're seeing. So here, I've given you 3 images, but they're likely to show you one after another. Let's go with the top left. So first you have to identify what eye this is. So this is the left eye, okay? Because of course, this is a well-oriented picture, but if the picture was not well-oriented, you have to try to see how the arcade is moving outwards. So the nasal arcade is more narrow, the temporal arcade is broader. So when the arcade is moving outward, the center of that should be the macula, and therefore this is the left eye. The first picture on the top is a macular center. The picture below is a disc center. These are 2 important terms, and these are the 2 terms that you need. And these are the 2 images you need sometimes to look at some aspects of ROP disease. Now the center larger picture is the temporal quadrant of the retina, and that's the most important quadrant to look for ROP disease. And here you will see that the disc is not seen. So it becomes all the more difficult to figure out which quadrant this is, I mean which eye this is. But again, if you follow those vessels, they are broader this way. So that's the temporal quadrant and not the nasal, which becomes more narrow. So, and also from in the nasal ora, when you're looking at the nasal quadrant, you will most of the time see a bit of the disc that will never go out of the view. But in the temporal, you can see out of the view. So identify the disc in the macula, follow the retinal vessels and see where they have ended. So these vessels have not gone till the end of the retina. They've gone a little beyond 50%. So this is important when you're characterizing how much immaturity there is, or you're describing the avascular-vascular junction, because that's where disease forms. So describe the normal and then develop. Now, this is not really part of the imaging thing, but for you to understand why the nasal aura gets vascularized earlier and the temporal aura gets vascularized later. And that's why temporal images are the most important. So if they ask you which is the most important quadrant, it's temporal. I'm not getting into the stages of ROP, but this is something you will have to know as a background, even for a separate question on ROP. And this is something new that the examiners would like to ask you, that earlier it was pre plus. No, sorry, there was no plus, pre plus and plus, but now we have a score. So this is called the P score. Okay. And this is based on the ICROP3 classification, which you will have next week. But here you can see P1, there is absolutely no plus, and P9, there is absolutely obvious plus. So there is some gradient in between. No details, but important to know. Now I put this picture here because this is a classical ROP picture. So here, if you have to first diagnose, you have to tell what stage it is, what zone it is, and whether there's plus or not. That's how simple ROP is. So here on the picture on your left, you are not seeing the disc. So again, what did we talk about it? This is the temporal quadrant. Which eye is it? It's the left eye. And what is this? This is, now let me tell you, it's stage 3. Once you've gone through the stages, you'll know this is stage 3, but that's coming next week. So which zone is it in? It is in zone 2. It's not in zone 1. Slightly different from the picture in front, right there in the middle. Now that's a zone 1, but that's now, this is a new term that's come in to ICROP, which is called the notch. So this notch going inside. Right? So the notch going inside means where it's going inside, that is the zone you have to talk about. So this is a notch in zone 1, and therefore it is zone 1. So this is stage 3 in zone 1 with pre plus, or you can call it P3 or P4. Now this is an aggressive ROP. So here I'm just going to put the questions quickly. So where is this disease located? It is in zone 1. What do the posterior pole vessels look like? Now the picture on the left is a lot of plus disease. There's dilatation and tortuosity. The picture on top is highly occluded, vasculitic looking with a lot of hemorrhage. And the one below, you can almost not see the vessels. So they're occlusive variety. All three are called aggressive ROP. So there are subtypes of aggressive ROP. Quickly to move on to the others. So this is the handheld OCT. So this is the American version, and we also now have an Indian version called the iXaner. And probably the guys who are making the Neo camera are also coming out with an OCT. So this is basically OCT Dr. Shailaja will cover, so I'm not getting into the details. But in infants, it really helps characterizing certain diseases, especially very useful for retinoblastomas and other tumors. So she'll talk about what an adult OCT layers look like. I just want to quickly show you that a baby's OCT is not going to be the same. I'll put out a reference in the end which talks about how to read an OCT of a baby. But just to summarize, these layers are not going to be fused when the baby is born. So this is the outer plexiform layer and this is the inner limiting layer, and they are not fused. And then there are other changes. And then these are some of our publications where you can see either changes in a baby in the macula or in the periphery. And some of these things not happening on time means that the baby is going to have lower vision. Now this is an angiogram, okay, and as phases are really important in adult angiogram, it's not so important in a pediatric angiogram. And this is done with a contact system. Again, it's done by the RetCam 3 or by the Neo camera, which we saw. The dose is important, 0.077 ml per kg of the 10% dye, the same dye that you use in pediatric. And what additional information it gives you? It will give you the capillary non-perfusion for sure, but it will also give you where the neovascularization is leaking. Okay, and this is to show you that it can happen on both the devices. The one on the left is the RetCam 3 and the one is on Neo diagnosis. So see how much information extra it gives you. In a color photo, you will think that the blood vessels are nicely reaching the end, but the angiogram shows you that they have stopped much before, and then that black area is still avascular. OCT angiography is not yet mainstream pediatric retinal imaging. You have to use the flying baby position. The advantage is the fact that you don't need to use a dye. And more of this will be on an OCTA talk. And this is how we adapt a baby to use an adult camera to take pediatric images. So then there are other advantages of getting the blue, green, and only the multicolor aspects of these adult cameras. Some of them are useful. And just for completion, there are other systems of imaging which have been invented in India, where you use a mobile phone and a 20 diopter or 28 diopter. It's on a stand. It's good for photo documentation, but not really for the periphery. And then 2 new cameras are coming, if you want to know that, and that's coming already this year. So the same guys who have made the adult camera are now making one, and this is going to be AI integrated. And the other one is the Appaswamy, you heard of them. They've also coming up with a RedCam camera. So when you see an OSCE on pediatric retinal imaging, name the instrument, find out whether it's contact or non-contact, what layer is it seeing, describe the normality, then the abnormality, what likely diagnosis, and then why is this important in a child? Yeah, identify, describe, interpret, and diagnose. This review article in IGO that we wrote a few years ago is useful. And the last one is the OCT, how to read an infant OCT. Thank you.
Yeah, Dr. Anand very well elaborated on imaging in pediatric retina. I just want to ask you one thing. Suppose in exam you get a picture of ultra field picture of retina. How do you differentiate between the ultra field and full field retina?
You're talking about a baby?
Any, suppose adult as well picture, adult or baby, whatever.
The ultra wide field as in 200 degrees versus just a regular wide field. So, okay, so I'll talk from a little more pediatric perspective. So if you're looking at the adult, if you're given an adult ultra wide field image of a baby, you're not going to be able to tell whether it belongs to a baby or not. It's going to look just like any adult retina. The magnification ratios of the optic nerve head, the macula, and the vessels will be very different. As against a wide field for us in pediatric is just 130 degrees. And these motifs that you see, that the ora serrata is seen only in the temporal retina, the nasal retinas will see sometimes the ora. These are the limiting factors. Whereas in an ultra wide field, like a Claris using an adult camera, or the Optos or the California based, it will not look very different. Only the pathology might look different. If you're looking at an FEVR in a baby, then it might look different. If you're looking at ROP, you will see that the retina peripheral is retinal is avascular. But just given an image of in an ultra wide of a normal baby or a normal pediatric child, you won't be able to tell whether it belongs to a baby or an adult.
Yeah, sometimes they ask you whether this image belongs to Clarius or Optos. Is there any way to find out?
I think someone who's doing adult imaging should answer this. I have not really had the experience of torturing my babies on both these systems, but except for the periphery. So I think if someone is using that, maybe. Between Optos and Claris, I have no idea.
Yeah, sir. Claris has a more of a true color image, and Optos has a RGB scale only. So there will be pseudo color. In Optos is slightly lower on the field of view, that is around 140 to 150 degrees, unless they montage it. But and generally the eyelashes don't come in Claris, but because there is an elliptical mirror in the Optos. There will be a pseudo color, and the eyelashes will be at the edges. So these are the other markers, but the basic technology and gives the color variation. So that's how you differentiate between the Claris and Mirante and all look the same. But Optos you can't miss because it is quite unique RGB.
Both RGB and RG are available. Only thing with RGB would be similar to true color, and the green color artifacts are missing along with the that you see in RG. But coming to Anand's talk per se, it was fantastic, Anand. What one should remember is that even besides postgraduates, these are also kept for those who are taking FICO those are taking fellowship exams also. So this is also helpful for that population who are training specially to be retina surgeons. So they can keep REDCam images, they can show it on a presentation, and questions could range from what is the diagnosis to what is the treatment, especially with anti-VEGF coming in. Certain aggressive ROP, images can be kept, and so that's how you need to prepare yourself. That's the reason we included this talk, because more and more centers are now, going into pediatric retinal imaging also, with ROP screening coming in and image documentation becoming so important. I think this is one new modality that we all needed to learn about. If any other questions from the panelists, Dr. Divya, Dr. Pradeep, would you like to add your inputs?
Maybe just like, other than ROP, even like not just neonates, but a little older children in conditions like FEVR, Coats disease, and other pediatric retinal diseases, it's important to document this, especially to when we follow up to see the changes, whether it is responding, especially in Coats disease and FEVR, to know whether the disease is still active or not. So it is very important to document these images. It helps in follow-up.
True, and it's also a good educative tool, because many a times, patients don't understand, even parents in the case of pediatrics, they need to understand what has happened. And with follow-up, how the disease is progressing, it definitely helps them a lot. Dr. Pradeep?
Yeah, nothing much from my end, ma'am. Like with this, my experience is limited with this.
Okay. Thanks. I think we'll go to the next speaker, Dr. Anjali.
Yes.
Yeah, Dr. Anjali, you can share your slides. Dr. Anjali has completed her medicine from Government Medical College, Calicut, and her MS from JIPMA, senior residency from LHMC, Delhi, and she's presently working as an assistant professor, Government TD Medical College, Alappuzha, Kerala. Over to you, Dr. Anjali.
Sorry. Yeah. Thank you, ma'am. Thank you, ma'am. First of all, let me thank the AOS ARC team for giving me this opportunity to talk about drugs and retina. So before going to the OSCE questions, sorry, hello.
Can just use the arrow there, no? The right arrow.
Just click on the screen, Dr. Anjali, and you should be able to move.
Somehow it got stuck.
Just click on the screen and you can move with the arrows.
Yeah, I'm clicking on the screen.
Now you can move from the arrows or
No, it's not coming.
Left
Would
bottom,
it be
there are
possible to minimize me from your side?
and just click on the screen, and from the keyboard you can start moving the slides.
Yeah, I'm clicking on the key screen.
You want me to stop it once so that you can
Yes,
reshare?
yes. Could you please do that?
You can reshare, please.
No, my screen is stuck. Okay.
Should we do the next talk in the meanwhile?
Yes, please. I'll come back there.
That we can say, Dr. Rajesh, you could introduce
Yeah,
Dr. Shailaja.
just a minute. We'll go to just a minute. We'll go to next talk by Dr.
Dr. Shailaja.
Dr. Shailaja. Yeah. My screen is visible. She is associate professor and VR consultant at KMC Manipal, and she has over 50 publications in peer-reviewed journals. And she will be talking on OCT.
Thank you. I'll share my screen. Am I audible now?
Yes,
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 Raj.
you can go ahead.
Yeah, I'll start. Learning how to interpret an OCT is important, not only from your examination point of view, where it can be asked as a part of OSCE, as a part of your fundus case presentation, as well as it can, some of the questions can come in the theory paper also. But it's also important in your clinical practice. You may have to take certain clinical decisions based on these. I'm sure most of you are well versed with OCT and have one or the other OCT, and some of you may be even using Swepsos OCTs. But today I'll be mainly showing the images which are taken from the Zeiss Cirrus, which is what I have in my center. So, because all of you are already well versed, then what is the point of having this presentation? Let me tell you this. If I show you this image, I'm sure all of you will be able to tell it's a tiger. But the important thing you need to do is not just tell it's a tiger, but to tell why it is a tiger. Or in other words, you have to describe the characteristic features, go in a methodical way, and finally tell that is why it is a tiger. So same way in the exams, most of the examiners, they'll either bring their own set of OCT images, or they may show you a OCT on the screen or a printout of the OCT, and you will be asked to interpret the OCT, and there will be a few questions following that. And the common tendency is to immediately to jump and tell the diagnosis because you know the diagnosis. But you need to go in a methodical way, step by step, analyze each layer, and then give a reasonable reason, and then finally come to the diagnosis. That is what will fetch you more marks as well as make you a better clinician. So to the left of this picture, what you are seeing is a HD image, and to the right is a 5-line raster HD, and to the right is a macular cube. So these are typical printouts which are usually given, and on the top of the image, there will be the demographic details of the patient. There will be the age, which is important because there will be usually a normative age-matched data. And you will have which scan protocol that is used, like the 5D raster or a macular cube. And also you need to look at the signal strength, because a good signal strength indicates a good quality scan. So anything above 5 and 6 is considered a good signal strength. Then you have the ETDRS thickness map. So this gives the average thickness of the central one, next the 3 and the 6 mm diameter circles. Especially important is the central subfield thickness, which is the average thickness in the central 1 mm circle. And also we have the central foveal thickness. All these measurements are done from the ILM to the RPE. Now, most of these OCT pictures may have these colored images, which is a pseudo color coding, but I personally prefer interpreting the images in the grayscale because that gives you can identify the subtle differences, pick it up better. Coming to the color coding, you have the hyper-reflective. The terminology we use in OCT is we either it is a hyper-reflective layer or a lesion, or a hypo-reflective or a medium reflectivity. So the hyper-reflective ones are the red and the white, which are the warm colors, and normally the nerve fiber layer and the RPE are hyper-reflective, whereas the plexiform and nuclear layer are medium reflective, and the black or the uniform structures like a fluid, etc. will appear black. And the nerve fiber layer thickness is increased nasally. That is how you can identify which eye it is. I recommend all of you read this article. This is the international nomenclature for the OCT landmarks, and this is how a normal OCT looks like. Earlier, Dr. Anand showed you the OCT of an adult and pediatric and told you how the layers are slightly different. But this is how the normal adult OCT with the normal sloping of the central fovea and the layers looks like. Most important to remember is there are a few hyperreflective layers, innermost being the nerve fiber layer, and outside you have the RP, the outermost, then the interdigitation zone, then the ellipsoid zone, and finally you have the external limiting membrane. The other layers are of moderate reflectivity. Now, how do you start interpreting an image when it is given to you? First, you look into the demographics, etc. And these are the 4 important things that you need to keep in mind. How is the vitreoretinal interface? How is the foveal contour? What is the how are the retinal layers and the intraretinal architecture, and finally you go to the RPE and the choroid. So starting with the vitreoretinal interface, most of the times the vitreous is black and it is hyporeflective layer, hyporeflective part. But sometimes you may have these hyperreflective dots indicative of vitreous cells, or rarely you may see this aggregate of hyperreflectivity causing shadowing underneath, classically described as the rain cloud sign seen in endogenous endophthalmitis. And normally the vitreous, when it is adherent to the underlying retina, you can't visualize it, but sometimes you have this perifoveal separation of the vitreous, where it is seen as a small, thin layer, which is attached at the fovea and separated in the perifoveal area without any disruption of the underlying retinal layers. So this is a vitreomacular adhesion. So you see here the foveal contour is normal. There is no abnormality in the underlying retina, and there is a separation of the perifoveal vitreous. This is a vitreomacular adhesion. And you compare it with this picture where you have the adhesion of the vitreous, which is separated in most of the areas except in the area where it is attached. But you can see the underlying retina is pulled and it is distorted. There is a distortion of the layers with the CME or SRD. This is what is known as vitreomacular traction. And when you look at this particular image, if you just look at the bottom picture, you can consider it to be a cystoid macular edema because you can see multiple small round cystic spaces hyporeflective. But you have to look at all the images. That is the importance of interpreting an OCT. You cannot decide just looking at one image. If you look at the other images, you can make out that it is actually a full thickness macular hole. So full thickness macular hole where there is loss of all the retinal layers with the vitreous which is adherent to one of the edges. So it is a stage 3 hole. And the size of the hole, you may be asked, the questions that can be asked along with this kind of OCT printout is, what are the stages of holes? What are the causes of holes? What is Vasquez-Allen test? What is the surgical approach for macular holes, etc. So this will be the spotter followed by these questions. And there are certain measurements which we deal with when we talk about macular holes. Next, we move on to a lamellar macular hole as opposed to the full thickness hole. Here you can see that it is a partial thickness defect. The outer retinal layers are intact. There is a wedge-shaped defect there with the epiretinal membrane and splitting of retinal layers. This is classically described as an anvil-shaped defect in the retina, as opposed to a pseudo hole where there is not actually a loss of the tissue associated with the epiretinal membrane. Lastly, in the vitreoretinal interface disorders, we have an epiretinal membrane, which is a thin hyperreflective sheet, which may be globally adherent or focally adherent, overlying the ILM. Here again, you may be asked about the stages of epiretinal membrane, what are the causes of epiretinal membrane, how does it clinically look like, etc. Moving on to the foveal contour. The normal foveal contour is with smooth downward slope. You may have abnormalities in the form of widening of the foveal contour, as in case of geographic atrophy where there is loss of retinal layers, or in cases of iridomacular degenerations like Stargardt's, etc. A classical one is a hydroxychloroquine toxicity where you have the loss of parafoveal outer layers with the preservation of the foveal layers, giving rise to the classical flying saucer sign. Now, obliteration of the foveal contour can occur from the fluid within the retina, like in macular edema or subretinal fluid, and rarely in patients with albinism when there is a foveal hypoplasia without having the normal foveal dip. Now we move on to the intraretinal architecture. So we have already seen in the normal OCT how the layers are compactly arranged. Sometimes you have edema fluid collection inside the retina. So edema being fluid, it is a homogeneous reflectivity. So it will appear as black or low reflective. Depending on how the fluid is arranged, you may have hyporeflective spaces in the inner or the outer retina with the intervening septae suggestive of CME. So when you see this picture, don't immediately tell it is CME. You describe it and then tell It could be a CM, it could be CME. Next questions that will be asked is what are the causes? So the commonest cause of CME being diabetes, diabetic macular edema. You can also get CME, especially in venous occlusions, central retinal vein occlusion, or in branch retinal vein occlusions where you have it in one particular quadrant. In central retinal vein occlusion, you have other signs of ischemia as inner layer hyperreflectivity, prominent middle limiting membrane, etc. Another important thing you need to know as a postgraduate is the definition of center involving and non-center involving DME. If the edema involves the central 1 mm, then it is called a center involving DME. If it doesn't, it is called a non-center involving, which has a therapeutic implications. And the patterns of diabetic macular edema, we have diffuse sponge-like thickening, cystoid edema, serous macular detachment, tractional edema secondary to epiretinal membrane or vitreomacular traction, sometimes a combination of these, which is a mixed type. Some important biomarkers in DME are DRIL, which is the disorganization of inner retinal layers. You can read about it. There are many articles on DRIL, but at least you need to know what is DRIL because it is asked in the exams. And you have to know hyperreflective foci and to know how to differentiate them from hard exudates. So if you see here, the hard exudates are the ones which are causing shadowing, whereas the hyperreflective foci are less than 30 microns and they do not cause any shadowing and have reflectivity similar to nerve fiber layer. Subretinal fluid is the collection of a fluid which appears black and hyporeflective under the retina above the RPE. The causes can be many, right from retinal detachment. One of the commonest conditions that we see is a central serous retinopathy, which is now a part of the pachychoroid spectrum. So you can see in this enhanced depth imaging picture, where the choroid is also imaged, you can see that the choroidal thickness is also increased. And there is a small PED, so this is a patient of CSR. Similarly, you can have multiple loculated fluids in inflammatory conditions like VKH. Here you can also appreciate that the choroid is slightly bumpy and thickened. That is how you differentiate it from CSR. Now, looking at this picture, you see hyporeflective spaces within the retina. Do not confuse it to the cystoid macular edema or cystic spaces in the retina, because you can see that the retinal thickness is lost. It is a thinned out retina. The retinal layers are lost in the outer retina. This is a MACTEL with the loss of retinal tissue and only the ILM remaining there, causing ILM drape. Moving on to the RPE choroidal complex. Normal RPE is a high reflective outermost layer. You can have thinned out or attenuated RPE with the loss of outer retinal layers in geographic atrophy, where you get increased signals from the underlying choroid that is called hypertransmission signals. This you can read out. It's difficult to cover it in this talk. And if you have humpy, bumpy, elevated RPE, it indicates drusen. Then you'll be asked about the sizes of drusen, types of drusen, all those questions related to drusen. Drusens can combine together, forming drusenoid pigment epithelial detachment. And the other types of pigment epithelial detachment, where you can see that the pigment epithelium is detached from the underlying Brooks membrane with a clear space in between, that is a serous pigment epithelial detachment. You can see the continuous Brooks membrane over there, as opposed to this pigment epithelial detachment, where there is a hyperreflective echoes from under the PED, that is a fibrovascular PED, indicative of a neovascular membrane growing underneath. It's a type 1 neovascular membrane, and the presence of subretinal fluid there indicates it's an active type 1 MNV requiring treatment. So CNVM, the most important thing you need to know is what type of CNVM it is and whether it's active or it is scarred. Coming to the type 2 MNV, the neovascular tissue is seen above the RPE, under the retina, and the presence of fluid before treatment and the regression of the CNVM after the fluid. You can also appreciate VMA there, which is one of the poor prognostic indicators. Lastly, I would like to just highlight PCV, which is now considered a part of the pachychoroid spectrum, which is very common in the Asian population. So not all of us have access to ICG to diagnose PCV. So if you see this type of large PEDs, with subretinal or intraretinal fluid, or flat irregular PED with sub-RP hyperreflectivity, PEDs, notched PEDs, double layer sign, all these are indicative of PCV. There is a nice article where they have given all the OCT signs to diagnose PCV. So you can read those articles. So to summarize, when you are given an OCT image, first look at the image, then tell it is OCT of the macula of which eye, right eye or left eye. What is the scan pattern, whether it's a line scan, radial scan, horizontal scan, vertical scan. How is the scan quality based on the signal strength? Comment on the vitreoretinal interface, whether it's normal, whether there is any VMA, VMT, epiretinal membrane, macular hole. Comment on the foveal contour, whether it's lost or it's normal. If it is lost, is it widened or obliterated? Then comment on the retinal layers and their arrangement, whether there is intraretinal fluid, subretinal fluid, schisis. How is the outer retinal layers, which is a very important prognostic indicator. Comment on the RP choriocapillaris complex. Comment on the presence of lucent PED, macular neovascularization, or PCV. This is some of the important things that I could think of in covering this. There are many more conditions, but mostly as postgraduates, I think this is what you will be expected to know. Other things, probably when you go for fellowship exams, you will need to know much more in detail. Thank you.
Thank you, Dr. Shailaja, for wonderfully explaining how to interpret the OCT printout. And your OCT printouts were really self-explanatory. I hope all the postgraduates, they will be benefited from your talk. Any comments from our?
Thank you.
It's a very nice talk, Dr. Shailaja ma'am. Like, one thing is, like, it's a very vast topic, to be honest. It's difficult to cover anything in such a short span, but ma'am made sure to touch upon everything which probably a postgraduate has to know. So one of the things, like, which I would always suggest, like, the postgraduates, like, is that, so use the terms like as ma'am mentioned, it's about the reflection of light and transmission of light. So always use the terms hyper-reflective, hypo-reflective, hyper-transmission, or hypotransmission, or shadowing. Whenever we see any finding, we can explain in this way. Even if we exactly don't know what it is, you can explain that it's an hypo-reflective space that I see, or an hyper-reflective lesion, hyper-reflective foci. You can use appropriate terms. That is one thing which, and particularly like cases in which there's a geographic atrophy, we see transmission of light beyond the RP and extending into the choroid. So hypertransmission, those terms, if we use that itself, gives an idea that to the examiner that, okay, yeah, he knows the concept. That is one. Second, as ma'am mentioned, like, always start with just don't jump into one particular thing. In the case of macular hole, definitely the hole will be so obvious that we will jump and say it's a macular hole. It's always better to start with, like, how is the vitreomacular interface, like, is the posterior cortical vitreous adherent to that edges. Then about the integrity of ellipsoid zone. In cases with high resolution scans, we can also make out the interdigitation zone and the external limiting membrane. So the integrity of these should be commented in each and every scan. You can actually talk about it in every scan. It's a case of cystoid macular edema. It's also, if you can mention that whether the ellipsoid zone is intact or not, that definitely adds to it, because it's a prognostic indicator for each and every disease. Whatever disease we are seeing, if we say that, okay, there is a cystoid, there are hyporeflective spaces within the outer nuclear layer, and always mention in terms of which layer that lesion is seen, like hyporeflective spaces in the outer nuclear layer suggestive of cystoid edema. And additionally, if you say that we can see that the ellipsoid zone is intact, indicating that the prognosis is good, that itself will add to it. So those are some of the things which you should try to look in each and every case. The vitreomacular interface, the retinal structures, the integrity of outer retina, like the outer retinal layers. So that adds to it actually. So any case for that matter, don't miss out on these two.
Thank you, Dr. Pradeep, for your comments. Quick comments from Dr. Divya.
Yeah, just to add, like in the OCT print, you can see that on the left side, there is an IR image will be shown. So it is a good idea to look at it, and there will be a marker on that. And the direction of the arrow will give you like from which quadrant or which direction the scan is being done, whether it is vertical, horizontal. So it is very important to see whether the scan has gone through your area of interest. So suppose it's a vein occlusion and it is on one half. So just make sure that if the scan has passed a vertical scan to see the difference between a normal inferior half and a superior edematous. So that is very important. So make a point to see the IR image also. And as madam was mentioning, the nerve fiber layer will be on the nasal aspect. So that helps us to give the identify the eye. And
Right.
one more point to add, if it is a 6 mm scan you are seeing, as Dr. Pradeep was mentioning, just trace the, if it is ISOS junction through the entire length of the scan. If you just see the center area, you might miss a dystrophy, which is where the ISOS junction is lost outside the subfoveal area. So always make it a point, you trace the entire line from the nasal throughout the entire scan length. That is very important so that you don't miss on any subtle findings.
Okay. Thank you, Dr. Divya. Dr. Ashray, any comments?
I think everything is well covered. Nice talk, Shalja ma'am. But more than all these things in OSCE, sometimes it progresses onto the allied questions, especially macular hole indices. At least you should know 3-4 indices: macular hole index, hole form factor, and tractional hole index, because that is how you are more answer those questions. And especially in PCV, all those Gemichuk's APOS paper, you should know all the 6 features that can be asked along with this. Very common OSCE question in most of the questions, either in FICO or in the for PGs. Those allied questions also you should know. What like now we talk about MNB type 1, type 2, type 3. These things you should have some idea so that you can write something on those topics as well.
Absolutely right. Dr. Chaitra, your
I
comments?
think all points have been well covered, and the panelists have put in more pertinent for the exam point of view as well. I think with this holistic presentation on all the potential conditions that can come, most of our postgraduates should be able to, take any of the questions that come in the OSCE. I think we'll go ahead with Dr. Anjali's talk now. Dr. Anjali, can you share your screen?
Yes, is it all right now?
Yes, yes, yes.
Yes.
Yeah.
So I'm sorry for the earlier glitch. Let me thank you all first for giving me this opportunity to talk about this topic, that is drugs used in retina. So before going to the OSCE as such, let's just talk about a few words on the drugs as such. That is, how do we deliver any drug to the retina? We can deliver it by topical eye drops, but there is poor posterior segment bioavailability in those. Systemic therapy, that is oral or intravenous administration. Then comes to the main thing, that is the intravitreal injection, which is the primary route for modern retinal therapies, and sustained release implants for long-term therapeutic levels. Now coming to each of them, what are the challenges in retinal drug delivery? We have anatomical and physiological barriers. Anterior root barriers, first let's talk about that. It's mainly for topical eye drops. Less than 1 to 5% of a topically applied drug reach the anterior segment. Very, very negligible amounts reach retina. Also, there is lacrimal clearance and blinking, which limits its presence in the eye. And also because of the corneal and conjunctival barriers, drug availability is less. That is, tight junctions in the corneal epithelium prevent hydrophilic molecules from passing through, while the vascularized conjunctiva clears drugs into the systemic circulation. Now coming to the intravenous or orally administered drug, even if a drug is injected or passes the outer layers, internal physiological structures limit its diffusion. We all know about blood-retinal barrier. The outer blood-retinal barrier composed of tight junctions between the retinal pigment epithelium cells and retinal capillary endothelial cells constituting the inner BRB. This regulates what enters the retinal tissue from systemic blood, preventing orally or intravenously administered drug from reaching the target concentration without toxic systemic doses. Also, there is vitreous humor resistance. Positively charged drugs bind to negatively charged hyaluronic acid, and large particles or molecules become physically trapped. Now, the standard clinical method to treat posterior segment diseases these days is intravitreal injection, but there is a problem of rapid clearance. Small molecules and biopharmaceuticals like anti-VEGFs are rapidly cleared via the posterior clearance, that is the retinal vessels, or the anterior clearance via the aqueous humor outflow, decreasing its half-life. This increases the treatment burden. Because the drug clears quickly, patients require frequent injections, often every 4 to 8 weeks. And this increases the risk and complications of intraocular delivery and also increases the financial burden to the patient. But there are several advantages as well. It bypasses the blood-retinal barrier to achieve targeted drug concentration, minimizes systemic exposure and off-target adverse effects, and enables localized, sustained-release treatment for posterior segment diseases. Now coming to the OSCE, what are the possible OSCE stations you can get in drugs in retina? Mostly a drug will be kept and different things and different questions on the drugs will be asked. So the usual drugs that are kept are anti-VEGF agents, which are the first line for neovascular exudative disease, intravitreal steroids, second line or inflammatory for inflammatory phenotypes, and also you can get some questions on procedural technique and emergency complications. So we'll try to deal with all of these. What are the major drug classes and indications that we use in retina? The anti-VEGF agents neutralize the vascular endothelial growth factor to reduce neovascularization and leakage. The common indications are wet AMD, diabetic macular edema, retinal vein occlusion, and several others. Key examples are ranibizumab, aflibercept, bevacizumab, and faricimab. Corticosteroids suppress inflammatory cytokines and restore inner blood retinal barrier, used in DME, especially refractory, uveitis, macular edema secondary to vein occlusions. The drugs are triamcinolone acetonide, dexamethasone implant, and fluocinolone. Antimicrobials have direct bactericidal, fungicidal, or virucidal action against intraocular pathogens, used in infectious endophthalmitis, antibiotics, antifungals, and antivirals. Now, what is the role of anti-VEGF? VEGF is a key signal protein that stimulates angiogenesis and increases vascular permeability. Hypoxia triggers overexpression of VEGF-A, which leads to fragile, leaky, abnormal blood vessels, that is neovascularization and macular edema, and which leads to severe vision loss and retinal condition. Our therapeutic role is to neutralize VEGF to halt vessel proliferation and reduce subretinal fluid and edema. Now, what are the indications? Another common question. Common indications are neovascular age-related macular degeneration, and it prevents CNV growth and photoreceptor damage in this. In diabetic retinopathy and macular edema, it reduces vascular leakage and improves visual acuity. In retinal vein occlusion, it controls macular edema secondary to vein occlusion. In myopic choroidal neovascularization, it targets myopic degeneration-related vessel growth. And in retinopathy of prematurity, it's an off-label use for zone 1 stage 3+ disease. The major anti-VEGF agents in use, again, another OSCE question. Bevacizumab, it's a full-length humanized monoclonal antibody, typical dosages and which VEGF it blocks. These things are very commonly asked. The typical dosage of bevacizumab is 1.25 milligram and 0.05 ml. It's used off-label, not FDA approved for use in eye. It's highly cost-effective but and binds VEGF-A. Next is ranibizumab. I think is the most commonly used drug now. It's a monoclonal antibody fragment, 0.3 milligram or 0.5 milligram in 0.05 ml. It's FDA approved, has high affinity, but there is rapid tissue clearance. Aflibercept, it's a recombinant fusion protein. It's also called VEGF trap, 2 milligram in 0.05 ml. It binds VEGF-A, VEGF-B, and placental growth factor with high affinity. Another question that can be asked here is why it's called a VEGF trap, because aflibercept acts as a double decoy. It has fragments of the VEGF receptor in the molecule itself. It tricks the VEGF molecule and the molecule gets attached to the drug instead of attaching to the tissue receptor, thereby preventing its expression. Next is a newer drug, faricimab. It's a bispecific antibody. The dosage is 6 milligram per 0.05 ml. It binds VEGF-A and angiopoietin-2. Now, this is the regimens that are used. First is the loading phase, monthly injections for 3 consecutive months to establish baseline disease control. Then we can use any of these maintenance strategies, but treat and extend is a preferred protocol. Injection interval is extended by 2 to 4 weeks if stable or shortened if active disease returns. Next is ProRenata, PRN, or as needed. Monthly monitoring, injection is given upon signs of recurrence, that is fluid on OCT. Next is fixed dosing strategy, fixed intervals, that is example every 8 to 16 weeks, depending on the drug and patient profile. Now coming to the next group of drug, corticosteroid therapy and sustained release molecules. Indication is refractory macular edema, post-cataract inflammation, and non-infectious uveitis. It is a potent anti-inflammatory and anti-angiogenic molecule and downregulates cytokine production and reduce macular edema. The formulations in use are triamcinolone acetonide, 4 milligram per 0.1 ml suspension. This is the normal dose that is used. We can also use low dose triamcinolone, that is 1 or 2 milligram. In that, the effectiveness remains almost the same, but the complications are relatively less. Next is dexamethasone implant, 0.7 milligram biodegradable intravitreal implant. It lasts for approximately 6 months. Next is fluocinolone acetonide. It's 0.59 milligram, non-biodegradable, insert for long-term control up to 36 months. Complications are intraocular pressure elevation leading to glaucoma and cataract progression. So these pictures, the pictures of the drugs can be kept, or the drug itself, or the injector, any of these can be kept for the OSCE. The Retisert is actually being discontinued by Bausch and Lomb, but still it is a possible question. Next, coming to intravitreal antimicrobials in infectious endophthalmitis management. The empirical antibiotics that we give are vancomycin 1 milligram in 0.1 ml for gram positive, and ceftazidime 2.25 milligram in 0.1 ml for gram negative. Antifungals in use are voriconazole 100 micrograms in 0.1 ml or amphotericin B 5 micrograms in 0.1 ml. Antivirals that can be used are ganciclovir 2 milligram in 0.5 ml or foscarnet 2.4 milligram in 0.1 ml for CMV retinitis and acute retinal necrosis. The crucial considerations here is strict dosing accuracy to avoid severe retinal toxicity like macular infarction. It is common in aminoglycosides, which is not commonly used now anyways. Now coming to the technique, another possible question, verify identity eye to be treated and obtain informed consent. Very, very important to verify the eye to be treated. Instill topical anesthetic, instill povidone-iodine, again, important for infection control. It's always better to use an eyelid speculum. We can measure 3.5 millimeter in pseudophakic or 4 millimeter in phakic posterior to the limbus in the infratemporal or supratemporal quadrant. The temporal quadrants are used for because it is easier to access, and also pars plana is broader there. In aphakia, a 3 millimeter, we can measure a 3 millimeter posterior to the limbus also. Insert a 30 gauge or 32 gauge needle perpendicular to the sclera into the vitreous body. Insert slowly, inject slowly, and remove slowly. No screwing action or shaking action while inserting or removing. Post-procedure, what to look for, confirm light perception, and monitor intraocular pressure spikes. Now, this is a small video. The drug is loaded. The patient is already on table. Topical anesthetic and povidone-iodine has already been instilled. That bud is dipped in lignocaine. It's measured, and the drug is injected. You can see it's slowly getting inserted. Drug is slowly getting injected. And the syringe is slowly getting removed. We sometimes see some fluid coming out when we remove the drug. It's mostly subconjunctival fluid or liquefied vitreous. But if vitreous gel comes out, we have to take care. Now, what are the complications? Procedure-related complications and drug-specific side effects. Procedure-related complications, chance of endophthalmitis, 0.05% risk per injection, subconjunctival hemorrhage, vitreous hemorrhage, retinal detachment, transient or sustained intraocular pressure spikes, and vitreous wick. Drug-specific side effects in steroids, cataract, high IOP, anti-VEGF, rare systemic cardiovascular risk leading to thromboembolic events. It's always a good idea to get a cardiovascular clearance before giving the patient the drug. How do we monitor? Immediate post-operative optic nerve head perfusion check and post-injection safety instructions. Now, we'll talk a little on retinal gene and cell therapy because future things may also be asked in OSCEs. It restores functional proteins or Hall's disease progression in genetic retinal dystrophies. Key therapies are voretigene neparvovec, AAV2 vector delivery for biallelic RPE65 mediated inherited retinal dystrophies, and complement inhibitors is used as targeted therapy for geographic atrophy secondary to AMD. Delivery may be subretinal injection or intravitreal administration. So these were the possible OSCE station we thought about. I showed before. I hope you can answer all these questions now. I mean, the PGs can answer all these questions now after this. Now, what is in the future? Transitioning from monthly injection to extended release formulations and gene therapy. Combination therapies like VEGF plus angiopoietin 2 inhibition to improve anatomical and visual outcomes. Now, what is the conclusion? Pharmacotherapy has revolutionized retinal care, shifting treatment from vision preservation to vision recovery. Thank you.
Thank you, Dr. Anjali. I think you've comprehensively covered all the potential drugs that can come. So most often for postgraduates to know is that they can keep any of the vials there. the used ones, or sometimes even drops can be kept in the carton. They can keep even some of the tablets like Diamox, for example. They will ask you the different indications. So we'll start with Ashray. Anything extra to add from what was already covered? I think Dr. Anjali has covered most of it. Anything?
Yes, ma'am. I think wonderful presentation on the extent of the drugs and all. But these days, I'm more interested in asking about the principal trials of these drugs which are used, especially the main protocols like Protocol T. At least the PG should be knowing about what are the outcomes in bevacizumab, ranibizumab, and aflibercept. At least the principal trials of aflibercept like view-1, view-2, rise and ride trials, and the newer Yosemite and Rhine and all these basic questions, if they are used and for FICO again, all these protocols will be of use, but definitely the different concentrations and different molecular weights, if it is known, then I'll be very impressed with that candidate.
That's interesting, actually, because it takes it one step forward, and if you know trials about these drugs, then I think that definitely will call for extra marks, because we tend to ask them indications, complications, but this is a new perspective. Pradeep?
Like one more thing would be like since the biosimilars have taken over most of the retina practice, like biosimilars is something which probably an examiner would be expecting a postgraduate to know. So they may probably ask like what is a biosimilar, how exactly they differ from the innovator molecule, and like that is something which probably if they are able to answer, that will be great. Then like another thing would be like the newer drugs which are approved by the FDA for indications like maybe like the drug for Mactel, which is approved by FDA. So the encapsulated cell technology with ciliary neurotropic factor, if they are aware, that would be great. But I'm not very sure like whether it will be asked, but if they know, it will be definitely great. And the one more thing I wanted to mention was like regarding the route of delivery. So usually they would mention intravitreal, topical, but suprachoroidal is something probably like maybe like is something which is getting more and more popular with even the newer drugs. Like the gene therapies which are targeting the suprachoroidal route. So that is something which probably, if they know, that would be great. The route of deliveries, if they ask route of deliveries, like how all you deliver, if someone says suprachoroidal, definitely it will add to it.
I think because that's one of the newest modalities that's available, and everybody's exploring it for just not only steroid, but like Dr. Pradeep mentioned, also for gene therapy. I think it's an important thing. If you add, you're just going to get extra points. And this is particularly true also for FICO, because that's something you must know as a FICO candidate. Dr. Divya, your thoughts?
I think almost everything is covered. Maybe the basic thing, like some examiners might ask in the practical OSCE, how to withdraw the drug. I mean, it is a good idea for the PGs to see how the drug is like in which vial, and how it is being like withdrawn. And even in the antibiotics, how do they reconstitute, and whether it is a powder, whether it is a like a liquid. So all these things, just have a look at least the cover and the package and all those things. It's a good idea to have a look.
Ma'am, just to add, actually gene therapy was there 10 marks question in the 2 years back only in the theory examination. So it is a very potential question in the upcoming exams.
Anand, would you like to add something, because we're talking about drugs and intravitreal for anything in specific, for pediatric retina itself? It may not be expected out of postgraduates, but definitely for fellows. Is there any special, technique or limitations for pediatric patients in whom now, since we're using anti-VEGF quite a bit?
Right. I think anti-VEGF, yes, definitely a big mainstay in ROP treatment. It's a topic on its own. But to summarize, the technique is slightly different. We use preferably a 32 gauge needle or a 30 if not available, and it is 4 millimeters. and the direction of insert going into the eye is different. In the adult, you go more oblique, as you even saw in the video, but in a baby, you would go much more vertically down, almost as though you're parallel to the lens. So the lens is a little more globular, more circular in a baby. The chances of hitting the lens is not easy to hit the lens unless you're really bad technique. But if it's a 4 mm needle, it really helps. You can go down up to the hub. The drug itself, Avastin, is the most commonly used. It's probably one of the better ones because it has the least chances of recurrence, and the recurrences, when they do occur, they occur later, and they're less severe. But it is off-label, since the mention was made by Dr. Anjali. And ranibizumab is the biosimilar. A couple of biosimilars in India are now getting recognized by the Indian DCGI. However, it's not FDA approved, and that's an interesting point because the only anti-VEGF for ROP that's FDA approved is actually aflibercept. This is just from a legal point of view. It doesn't mean that it cannot be used, and off-label doesn't mean illegal. In fact, we have a legal paper coming up. It just means that it was not made for that indication. And with Avastin and ranibizumab being made by the original company, the same one, there's going to be a financial problem on how they will not promote one over the other. So Avastin has the best outcome in terms of the least recurrences and the most later recurrences. Aflibercept is somewhere in between, and ranibizumab has the earliest recurrences. On an average, 4 to 6 weeks for ranibizumab, 6 to 10 weeks for aflibercept, and 10 to 12 weeks or 12 to 16 weeks sometimes for Avastin or bevacizumab. That's probably something they might want to know.
Yes. I think that kind of sums up all our talks for today. The faculty were excellent. I'm sure the PGs are going to benefit from this because there's also recording available for them to go through, just before their exams. And almost every detail of what can potentially come with respect to drugs or pediatric retinal imaging or OCT has been covered. I don't think, they really need to refer to any other material. All of it has been wonderfully covered. So thanks to all the faculty. And the panelists, I think, just added so much more value by giving the smaller nuances, by giving these extra points that one could not think about on a routine basis. And you'll never know. If you have an examiner like Ashra, you'll be surprised. So all of y'all, wishing you all the very best. Thank you, Divya, Ashray, Pradeep, Shailaja, Anand, and I don't know where Dr. Anjali is, but yeah, thank you so much. It was really fantastic, and thanks for sparing your time. I know it's a busy working day at the end of it. To sit through a webinar is not easy. I hope the postgraduates do benefit from it, and thanks to my co-moderator, Dr. Rajesh, as well. Thank you.